I have a confession to make. I'm not, never will be, an information specialist. I come at this whole area from the clinician point of view. I'm trying to keep it real for clinicians because it's the only way I can understand any of what's going on. So I frequently ask, for my own benefit, what I see as relatively simple questions. I'm kind of blown away by a lot of the work that's being done here and presented this morning, but I still think there's room for clinicians to ask the questions that make all of this manageable for us and therefore our patients. I have come at this through starting my institution's lung cancer MDT and developing our database clumsily and in a ham-fisted fashion, but it's getting better all the time. And so I've learned a lot about how clinicians use data, which is mostly quite badly, I think. Not the clinicians in this room, but in general. And there's a lot of lung cancer data that's around us, but like the ancient mariner, you might be thirsty, but Jeff Delaney has told us that it could be 3 years till you get a drink. Data on lung cancer are everywhere, but they're trapped. They're trapped in silos, and we've heard a lot about really wonderful linkage work to try and get access to that data. And this is a little map that I've drawn for myself on some of the ways data are linked together. Please don't try and read the writing because it is a tiny screen, but in the middle is the New South Wales Cancer Registry, and around it are some of the radiation oncology management systems, private hospital data, which has been, maybe it's changing, relatively inaccessible, and the now extinct clinical cancer registry was really my first introduction to registry people. And I'm starting to develop a protocol to test clinician data access, and I appreciate that we're hearing a lot about very sophisticated strategies, but I still think there is room to train clinicians and educate us in how to understand the data that's around us and how to get access to it. And hopefully over time it will become a lot easier than as we have seen. So I'm very interested in the fact that hospital data, which is the data that I can access relatively easily, as long as I'm in my institution, I've got my password, but a lot of that data has limitations when it comes to longitudinal information and cross-institutional information, so I can track what happens to my patient. It's clumsy, it's a little bit disjointed, but I can do it, but I can't get a really seamless sense of what's happened to them. I'm doing a lot of work on multidisciplinary team data, and the circles, again, don't read the writing, show that at the centre of everything is the MDT data collection, which certainly for lung in Australia is not standardised yet, but we're working on it. And around that, I think, sit data that's useful for audit, and one of my models is the UK National Lung Cancer Audit. Around that are administrative and registry data sets, which we're hearing a lot about today, and then there's the beyond. So I'm going to take some of my data sets that I've developed and ask some test questions of important data settings, and some of you will recognise your own logos, but there's hospital databases like Peter Mac, the all-important Queensland Oncology Online data tool that we'll hear about from Shoni Philpott later, state-based registries, whether they're general cancer or the Victorian Lung Cancer Registries, and the international models we've heard about. I think the clinician access to data is at the moment completely hampered, or maybe even completely blocked in some cases, by these really cumbersome strategies. And I think anybody who's a clinician working in clinic will know that if it takes more than 1.5 seconds to get to a piece of information, you move on because you don't have a whole lot of time. So there's a real time pressure when you're actually with a patient. We all want real-time data when we're with real patients, but the time pressure is enormous for clinicians, and I think that creative strategies will have to be employed to address that. I have found, even in my own institution, again on the right it's tiny, but I've tried to track the sources of data into the data domains that I can use. So I've put ClinCR in the middle there, but you could replace it with the MDT or even the eHealth record that I can tap into. And around that sit things like my MDT database, the particular eHealth record that St Vincent's uses, a clumsy second version of the non-integrated eHealth record, some palliative care data. And so all of those feed into the data set that I use, and if I don't understand the sources of those data, I can't critically analyse or assess the data I'm using. And on the right, in my last 20 seconds, is a graph from a Victorian paper looking at colorectal cancer, which can show what happens to your understanding of your patient group when you infuse extra data. This is a survival curve over years, and it shows, don't read the numbers, but it shows that The top curve is survival shown in the hospital's databases, which shows a 5-year survival of all stages of 70%, or maybe it was a particular stage, I can't remember. They infused mortality data from registry information and they dropped their mortality. Their mortality worsened by 10%. So if you don't know where your data is coming from, you don't really understand its quality. And that's where I'm working. And this is my PhD supervisor team, because this is all part of a PhD, and I'd like to thank them very much.